A randomized controlled trial of nearly 26,000 adults, one of the largest supplement trials ever conducted, found that omega-3 fatty acid supplementation was associated with a 28% reduction in the risk of myocardial infarction. That is a heart attack. 28%. In a rigorously designed study, not an observational survey. For men and women over 55 who are thinking seriously about cardiovascular risk, this finding sits at the center of one of the most important supplement debates in modern medicine. But as always with landmark research, the headline number is only part of what the data reveals. Here is why this matters specifically for the 55-plus age group. Cardiovascular events do not arrive without a long period of silent risk accumulation. By the time a person reaches their late 50s with moderately elevated LDL, a family history of coronary disease, or a waistline that has expanded through middle age, the arterial environment has been building risk for decades. The question of whether a widely available and well-tolerated supplement can meaningfully reduce the probability of an event is not a trivial one. The VITAL trial was designed to answer exactly that question in a population that was not already sick, not already post-event, but managing preventive risk. The 28% reduction in heart attacks reported in this trial is a secondary endpoint result, and that distinction has technical implications we will discuss. But the magnitude of the finding and the quality of the trial design make this a study that deserves careful and unhurried examination. In this video, we will examine the VITAL trial in detail, its design, its population, its primary and secondary findings, and critically, what those findings mean for someone in the 55 to 68 age range. We will look at who benefited most, what dose was used, how fish consumption changes the equation, and where the evidence stops and the inference begins. We will also cover the REDUCE-IT trial context, the EPA versus DHA debate, and the label reading distinction that makes a significant practical difference when choosing a supplement. Quick note before we begin, this is educational content based on published research, not medical advice. Talk to your physician before changing your regimen. Now, the study. Cardiovascular disease remains the leading cause of death in adults over 55 across the United States, United Kingdom, Canada, and Australia. For decades, epidemiological research pointed to populations with high fish consumption, particularly Japanese and Greenlandic communities, as having lower rates of heart disease. The hypothesis was compelling. Omega-3 fatty acids, specifically eicosapentaenoic acid and docosahexaenoic acid EPA and DHA, appeared to reduce inflammation, improve triglyceride levels, stabilize cardiac rhythm, and support arterial function. But epidemiology can only identify associations. It cannot tell us whether supplementing with concentrated omega-3 extracts provides the same benefit as eating whole fish in the context of a broader dietary pattern. Early trials in the 1980s and 90s, the DART trial and the Italian GISI Prevenzione trial, produced encouraging results, but both studied post-heart attack populations. By the 2010s, the critical unanswered question was whether omega-3 supplementation reduces cardiovascular events in people without prior heart disease. Healthy middle-aged and older adults, the group managing risk rather than managing a diagnosis, were substantially underrepresented in the existing evidence base. This is the population most likely to be buying fish oil at the pharmacy. The VITAL trial was designed specifically to close that gap. A study published in the New England Journal of Medicine by Manson and colleagues from the VITAL Research Group enrolled 25,871 men and women across the United States, men 50 or older, women 55 or older, without prior cardiovascular disease or cancer at enrollment. Participants were randomized in a 2x2 factorial design, omega-3 plus vitamin D, omega-3 plus placebo, vitamin D plus placebo omega-3, or double placebo. The omega-3 dose was 1 gram per day of EPA and DHA combined, lower than the 2 to 4 grams used therapeutically for triglyceride reduction, and substantially lower than the 4 gram per day dose in the REDUCE-IT trial. The VITAL dose represents what most commercial fish oil supplements deliver. Follow-up ran for a median of 5.3 years. The primary endpoint was a composite of major adverse cardiovascular events, myocardial infarction, stroke, and cardiovascular death. Cancer incidence was a co-primary endpoint. What the researchers found at the primary composite level was non-significant. The overall cardiovascular event rate was not significantly different between groups. In rigorous clinical trial reporting, this is the result the trial is most often summarized by, and that summary is accurate but incomplete. But that's not where the story ends. When researchers examined individual components of that composite, heart attacks specifically, separated from strokes and cardiovascular deaths, the data told a meaningfully different story. And when they examined fish consumption patterns within the cohort, that analysis is where this trial becomes most instructive for the 55-plus audience. The researchers reported a 28% reduction in myocardial infarction risk in the omega-3 group compared to placebo. Heart attacks, not strokes, not all cardiovascular deaths together, but heart attacks specifically, were significantly less frequent in the group receiving 1 gram per day of EPA and DHA combined. Now, it is important to be precise here. This was a secondary endpoint, not the primary composite. That distinction matters for statistical interpretation. When a trial's primary endpoint does not reach significance, as was the case with the composite cardiovascular event rate and vital findings in secondary endpoints, even pre-specified ones, carry somewhat less inferential weight. They are hypothesis-generating and clinically meaningful, but they are not the definitive confirmatory result the trial was powered to detect. The researchers and subsequent editorials acknowledged this distinction clearly. Anyone representing the vital data without acknowledging that the primary endpoint was null is presenting an incomplete picture. What the researchers found next is even more important for this age group. When the cohort was stratified by fish consumption at baseline, participants who reported eating less than 1.5 servings of fish per week, that is, low fish consumers, showed a 40% reduction in myocardial infarction risk with supplementation. The effect was substantially more pronounced in people whose dietary omega-3 intake was lowest to begin with. This dose-response relationship makes biological sense. If someone is already obtaining adequate EPA and DHA from regular dietary fish consumption, supplementing adds to a pool that may already be near saturation. If baseline intake is low, there is considerably more room for supplementation to shift the needle on platelet aggregation, triglyceride levels, and anti-inflammatory signaling. The study also observed that participants who were African American showed a particularly strong effect on myocardial infarction outcomes, with a substantially higher relative risk reduction than the overall population. This subgroup was smaller than the overall trial, and findings in smaller subgroups should be interpreted with caution given the increased probability of statistical noise, but the observation is consistent with data from other cardiovascular trials suggesting that African American populations may show differential responses to certain lipid-modifying interventions. Triglyceride levels, as expected from earlier research, showed a favorable reduction in the omega-3 group. The supplement was well tolerated across 5+ years of follow-up. There was no significant increase in bleeding events at the 1 gram per day dose, a theoretical concern that had been raised about higher dose omega-3 supplementation. And cancer incidence, the co-primary endpoint, was not significantly different between groups, which is itself a reassuring null finding. The limitations of this study deserve attention before we act on it. The most important consideration is the one already noted: the primary composite endpoint was null. In clinical trial methodology, when the primary endpoint does not reach significance, findings in secondary endpoints are hypothesis-generating rather than confirmatory. The myocardial infarction finding is important and biologically plausible, but the trial was not powered or designed to be definitive on that specific question alone. Researchers and regulatory bodies set primary endpoints in advance precisely to prevent the selective reporting of favorable subgroup results from trials that did not achieve their main objective. This is not a technicality, it is the scientific infrastructure that prevents the literature from being shaped by post-hoc cherry-picking. The dose of 1 gram per day is a critical variable that deserves direct engagement. Many cardiologists using omega-3 therapeutically, particularly the high-dose prescription formulation of icosapentaenoic acid ethyl ester at 4 grams per day, which showed significant reductions in cardiovascular events in the REDUCE-IT trial in high-risk patients, argue that 1 gram may be insufficient for meaningful cardiovascular protection in the absence of very low dietary intake. The VITAL trial and REDUCE-IT used different formulations, different populations, different doses, and were asking different questions. Direct comparison between them is methodologically problematic. But the dose dependence of omega-3 effects on triglycerides and inflammation is well established, and 1 gram sits at the lower end of the pharmacologically active range.
There is also the unresolved question of what kind of omega-3 matters most. EPA alone versus EPA plus DHA has been an area of active scientific debate, with some researchers drawing on mechanistic data and the REDUCE-IT finding, which used pure EPA, arguing that DHA may partially attenuate EPA's cardiovascular benefits. This hypothesis remains contested, and the vital formulation combined both EPA and DHA, so it cannot contribute directly to resolving that specific debate. What this trial adds to the literature is a high-quality, long-duration, randomized signal in a healthy, community-based, older population, one that suggests low dietary fish consumers appear to benefit meaningfully from supplementation in terms of heart attack risk. When combined with the broader omega-3 literature, including meta-analyses showing consistent triglyceride-lowering effects and anti-inflammatory properties across dozens of trials, the overall picture points toward a favorable risk-benefit profile at 1 gram per day for most adults without existing kidney disease or bleeding disorders. But the headline should not be misread as representing settled, universal science for all populations and all doses. 3 practical takeaways from this research, grounded specifically in what the VITAL trial tells people in the 55 to 68 age range. Takeaway 1: Know your fish consumption baseline before deciding on supplementation. The VITAL data suggests that the benefit of 1 gram per day of EPA and DHA was most pronounced in people eating fewer than 1.5 servings of fish per week. If your typical week includes 2 or more servings of fatty fish, salmon, sardines, mackerel, herring, you may already be obtaining meaningful dietary omega-3 intake, and the incremental benefit of adding a supplement is likely smaller than it would be for someone whose diet is low in fish. If your diet is consistently low in fish, a very common pattern in adults who do not actively eat seafood, the evidence from VITAL suggests that supplementation at around 1 gram per day of EPA and DHA combined is a reasonable option to discuss with your physician. The target is not to replace dietary fish, which carries additional nutritional benefits beyond omega-3 content, but to address a specific gap in a way that the trial suggests may reduce myocardial infarction risk. Tracking fish intake for 1 week, honestly, is a useful first step that most adults have never done. Takeaway 2: If supplementation is appropriate for you, focus on the combined EPA and DHA content on the label, not the total weight of the capsule. This is a practical distinction that makes a significant difference. Many products sold commercially as a 1 gram omega-3 supplement contain fish oil at 1 gram total weight, but the actual EPA plus DHA content may be only 300 to 500 milligrams, less than half the dose used in the VITAL trial. What Manson and colleagues used was 1 gram of EPA and DHA combined. To match that dose, read the supplement facts panel and look specifically for the combined EPA plus DHA figure. Concentration matters. A higher concentration product delivers more active ingredient per capsule, which affects both efficacy and cost per effective dose. If your physician determines this is appropriate for you, this label reading step is not a minor detail, it is the difference between replicating the trial conditions and taking a fraction of the studied dose. Takeaway 3: Omega-3 supplementation sits within a broader cardiovascular risk management framework, not outside it or above it. The VITAL data showing a 28% reduction in myocardial infarction is a meaningful finding, but it does not displace the primacy of LDL management, blood pressure control, physical activity, smoking cessation, and dietary pattern in cardiovascular risk reduction. These are the foundational variables, the ones with the largest and most consistently replicated effect sizes in the literature. Omega-3 supplementation addresses one biological variable within a multifactorial system. If someone is not yet addressing elevated LDL, uncontrolled blood pressure, or a fasting glucose trending toward prediabetes, adding a fish oil capsule without addressing those factors is not a sound prioritization. There's a catch that matters specifically if you're over 55. Cardiovascular risk is multifactorial, and the evidence-based approach is to know your numbers: LDL, ApoB if available, blood pressure, fasting glucose, triglycerides, and Lp(a), before deciding where supplementation fits in your overall strategy. The biomarker PDF guide linked in the description walks through exactly which panel values matter most and what ranges to prioritize in conversation with your physician. The VITAL trial represents a significant piece of evidence in the omega-3 story, a 28% reduction in heart attack risk,
most pronounced in low fish consumers, from a well-designed randomized trial in a healthy, older population. The primary endpoint was null, the dose question is unresolved, and the EPA versus DHA debate continues, but the directional signal from this research, placed in the context of the broader omega-3 literature, points toward a favorable risk-benefit profile at 1 gram per day for most adults managing cardiovascular risk after 55. This is not a compound with dramatic side effects at low doses. It is an inexpensive, widely available intervention with a plausible biological mechanism, a large and generally consistent evidence base, and a specific signal of benefit in the population most likely watching this video. That combination justifies a conversation with your physician. Download the PDF guide on reading your biomarker panel, it is linked in the description, and bring those numbers to your next appointment. If this kind of careful, unhurried analysis of the evidence is useful to you, subscribe so you do not miss the next video in this series.
This is educational content, not medical advice. Always consult with your physician before changing your regimen.
Studies are preliminary, individual responses vary.